Congenital syphilis might show up, but again, you should have a maternal history of syphilis. Skeletal dysplasias, osteogenesis imperfecta, and Ehlers-Danlos syndrome are the two big ones. Ehlers-Danlos syndrome, likely those children will have elastic skin or very hyperextensible joints. The metabolic and nutritional bone diseases, osteoporosis, scurvy, and rickets, secondary hypoparathyroidism, Menkes kinky hair syndrome. If the child has been on drugs, prostaglandins, methotrexate, or high doses of vitamin A. And then children who are unable to move properly, kids with cerebral palsy or spinal dysraphism, their bones tend to be osteopenic from lack of movement, and they will fracture more easily than their peers. And then neoplasms also should play into the differential. Again, it should be pretty obvious that with a few simple lab tests and a good history and physical examination, you should be able to take care of these particular things. A word about vitamin D. There is no vitamin D level at which anybody has identified that bones fracture more easily. We have seen vitamin D levels here down to 3, and the child has had no fractures. So there are no good studies out there on what level of vitamin D is too low. And I guarantee you we all have low vitamin D, and hopefully it's not running around with too many fractures. Okay, so this is what rickets looks like. And you should know about rickets for your endocrinology portion of this, as well as your nutritional portion of this, as well as for your child abuse portion. So you do get a rachitic rosary sometimes with rickets, but you will also get this fraying and cupping of the ends of the long bone. So it looks different if you think back to those classic metaphyseal lesions, but maybe in the differential. Osteogenesis imperfecta, you will have washed out osteopenic appearing bones. They will be bowed. You can see those bowing tibias and fibulas over there on the upper right hand side, and you may see Wormian bones in the skull. So if you're presented with something like this is probably OI. These children also break more easily. So basically the identification of abusive fractures is based on the entire clinical evaluation: history, physical exam, age and development, fracture type and specificity. We talked about some fractures being more specific to child abuse than others. And then a consideration of the differential diagnosis and the appropriate workup. Abusive head trauma is the most common cause of mortality and morbidity related to physical abuse. So when a child less than the age of 3 years of age has a history of serious head injury without a history of major trauma, you have to consider inflicted head injury. Basically, abusive head trauma, we no longer call it shaken baby syndrome, is violent rotational forces with acceleration and deceleration with or without impact that causes stretching and shearing of bridging veins and disruption of the neuronal connections. So the damage in abusive head trauma is not the blood. The blood is the marker for what's going on inside of the brain, for what has happened biomechanically inside of that brain. And when you get shearing of the bridging veins and the shearing of the neuronal connections, that's when you get brain death, brain swelling, and brain death. So some of you know, we just saw her in clinic the other day, Anaya Foster, who was in a PICU for a while and was a pretty bad abusive head trauma child. She now has significant microcephaly because unfortunately a great amount of her brain was killed during her abusive episode. Anatomic factors that make young children more prone to head trauma: they have a large head to body ratio, they have poor postural head and neck control, and the size of the perpetrator is quite large compared to the size of the victim. There are actually a number of case reports in the literature, coming out of the military literature, of large military people shaking smaller enemy personnel and causing abusive head trauma types of injuries. So the size of the perpetrator versus the size of the victim does play a role. So the clinical presentation of abusive head trauma can be variable depending on the amount of brain damage. It could just be simply irritability, lethargy, and limpness. 40 to 70% of the children will present with seizures. There may be a difficulty of feeding or vomiting. There may be hypoventilation, hypothermia, and bradycardia, coma, decreased responsiveness, and death. The more subtle presentations, including vomiting, irritability, developmental delay, and increasing head circumference, may go missed for a while. And we know that 30% of abusive head trauma is missed on the initial presentation because the symptoms are so subtle. They're very similar to sepsis, right? Irritability, lethargy, limpness, vomiting. Um, so if it's just irritability and maybe a little fever because there's free blood in the head, that child may be misdiagnosed as having a viral syndrome or having an otitis media. So there is a huge problem with these children being missed early on when their symptoms are subtle and they cross over to other types of childhood illnesses, which are actually far more common. So the physical injuries, there is a triad of findings that are considered classic, but you do not need to have all three of these to diagnose abusive head trauma. Brain injury, notice I didn't say blood there, brain injury. Fractures, most often rib and the classic metaphyseal fracture, and retinal hemorrhages. Remember, these children may often have no outward signs of injury, but you may have some bruising around the rib cage where children are likely to have been grabbed. So the brain injury, so here you have a subdural hemorrhage on this child's right side. You also have significant cerebral edema, so that's your brain injury, correct? And the brain is sort of migrating over there towards the left side. So this is a child who's got some significant problems. The bleeding may be subdural or subarachnoid, and remember, it's a marker for what is potentially going on underneath. Retinal hemorrhages are present in over 50% of children with abusive head trauma. So if you look at that top right picture, diffuse, multi-layer, out to the periphery of the retina are the most specific for abusive head trauma. Retinal hemorrhages are more common in abusive head trauma than in accidental head injuries. You may get one or two retinal hemorrhages by the posterior pole of the retina with some accidental injuries. Now, can children with a bleeding dysplasia or with certain kinds of cancers get retinal hemorrhages? Yes, they can, but they're not going to look like that top right-hand side picture. Again, the posterior rib fractures, and there you can see the mechanism. And over there, the classic metaphyseal lesion that may go along with abusive head trauma. Other fractures can also go along with abusive head trauma, and remember, abdominal injury can also go along with abusive head trauma. So, again, history is the most important thing. So the no history, if you get the no history thing, you should always be worried. Or a history of a short fall from a couch, from a bed, changing table, or down the stairs. When children fall downstairs, they roll. They don't fall like we do, 6 feet or 5 feet before we land. These are always very worrisome histories for abusive head trauma. Physical examination, and this might show up. Remember your ABC. So if they say, what do you do first? You stabilize the patient, right? The exam has to be complete. If you ignore less urgently compromised organ systems, that can be fatal, ignoring bleeding visceral organs. You need to check the skin for bruises. You need to check the oral cavity, the neck, and the anogenital area. You need to examine the retina, and you need to document your physical exam very well. So the imaging studies, the first modality for abusive head trauma is always the head CT. It does not have to be contrast. Head CT without contrast. Bone windows should be used to check for skull fractures. But in this day and age now when we can do 3D CTs, that's fine. But if the CT is not gotten so that you can do a 3D recreation, you have to get skull films because you can miss skull fractures on CT. So plain radiographs for the skull are best for fractures. MRI we do now on a regular basis. It gives superior detail of the brain parenchyma. It lets us know what kind of underlying injury there is there. It also lets us see smaller subdural hematomas and lets us characterize the hematomas better. We don't generally do the MRI until 1 or 2 days into the event in order to maximize our return. It's now also being recommended that the MRI include the C-spine. I don't know if that's going to show up yet on the boards this year to look for spinal cord injury in the C-spine. Skeletal survey, again, you would do with any suspected abusive head trauma, and you may need to repeat again to visualize rib fractures that might be missed early on. And abdominal CT should always be considered because if you ignore it, the child may succumb to abdominal injury. So again, the lab studies are guided by the clinical presentation and the severity of the injury, and again, consider injury to other organ systems. So you want to do a coag profile, preferably before you give the child fresh frozen plasma and a blood transfusion, CBC and serial hematocrits, because children can bleed a lot into this subdural space. You want to check the electrolytes, the BUN, the creatinine, and the osmolality, because children can develop SIADH as a consequence of abusive head trauma. And then the other things we've pretty much already talked about. There are mimics of abusive head trauma, rare metabolic disorders that can present with findings similar to those associated with abusive head trauma. So you need to consider consultation with the appropriate subspecialist and screening for metabolic disorders. So in Illinois now, glutaric aciduria is included on the newborn screen. Still, if we get a very young infant in with a situation but glutaric aciduria doesn't cause bone fractures, FYI. But still, we would probably repeat the glutaric aciduria testing on a very young infant. Clotting disorders can certainly present as abusive head trauma, but again, they're not going to cause fractures, right? Vitamin K deficiency. If you are presented, by the way, with a child who's born at home and has an intracranial bleed a week or 10 days later, and they ask if you want the vitamin K level, the answer is yes, you want it. Because some home births, legally they are supposed to give vitamin K, but oftentimes they don't. Internal injuries are the second most common cause of physical abuse-related death, and maternally rated about 45 to 50%. It occurs from exsanguination from ruptured blood vessels or shock and sepsis from a ruptured hollow organ. These children are often older than the abusive head trauma victims, but they're younger than the accidental abdominal injury patients. So the accidental abdominal injury patients are hockey players, perhaps. They might be kids who are riding bicycles, who are climbing on the monkey bars, are going to do something where they're going to get a sudden, sharp impact trauma to their belly. The average age where we see abusive abdominal injury is around the age starting around 2 to 4 years of age. Children still have relatively protuberant abdomens. They're doing something obnoxious. They're peeing in their pants. They're pooping. Something is going on, and somebody takes a quick fist or a quick kick into their abdomen. Potty training and provocative toddler behaviors are pretty much the two main precipitants of abusive internal injury, and the cause is direct impact to the chest or abdomen. There's often no outward signs of trauma, right? So if you bump into something and you bruise your forearm or your elbow, you're going to know that pretty quickly because there's not a whole lot of fat. There's not much there to protect from the trauma. When you punch into a belly or you kick into a belly, the forces are directed internally, so the bruising happens internally. But if you see a child with an abdominal bruise on the outside, you should definitely proceed with working them up for abdominal trauma. So, again, these injuries are uncommon in childhood from all causes, but when they're present, they may be life-threatening. Again, like abusive head trauma, the manifestations are varied and the symptoms may be subtle and mistaken for a routine pediatric illness. So Abdominal pain, vomiting. How many children present with abdominal pain and vomiting? Just about every kid on earth. Okay? So you always need to keep this in your differential. Trouble breathing, altered mental status, cardiac or respiratory arrest, and sometimes they're found incidentally when you're working the child up for some other type of thing. Again, the history is the most important thing. A misleading history or other serious distracting injuries are what delay the diagnosis. So, if you're a mom or a dad and you come home and somebody has kicked your child in the belly and your child tells you that they have a bellyache, you would not know if it's anything worse than the more routine bellyache until your child progresses along here and starts having trouble breathing or something else is going on. So here's just sort of a diagrammatic picture of what happens. So you can have lacerations of the solid organs, you can have rupture of the hollow organs, and you can have tearing of the mesenteric vasculature. All of these are sort of shearing, sudden impact injuries to the abdomen. Here's a little fellow here that actually did have a liver laceration, but he presented with this big old abdominal bruise right over his belly, and he said that somebody had punched him there, so we knew to go hunting for something else. So things that you might see here: free air in the belly, give you an indication that there is a ruptured hollow viscus. An intestinal hematoma. These are the children that will be vomiting, that will not be tolerating their feeds very well. Liver lacerations. If you are presented with a child with elevated liver enzymes and something else is funky in the presentation, or there's some other form of trauma, you need to think about liver laceration. Okay. All right. Sexual abuse. Risk factors for sexual abuse. There are no socioeconomic or racial risk factors. There may be concomitant poor parent-child relationships, poor relationships between the parents, the absence of a protective parent, and that doesn't have to be a physical absence. It can be an emotional or mental absence of that parent, or drug-induced absence of that parent, or the presence of a non-biologically related male in the home. This is one time in child abuse where this is significant and important. So intrafamilial child sexual abuse occurs oftentimes in the context of other family problems. So there may be concomitant physical abuse. There's almost always concomitant emotional abuse. There may be substance abuse, neglect, or other forms of family violence going on, either elder abuse or domestic violence. So what do we know? We know about 1/4 of girls report being victimized before the age of 18, and about 1 in 10 boys report having been victimized before the age of 18. This is not just intrafamilial. This also includes extrafamilial sexual abuse, but intrafamilial makes up the greatest proportion of it. The median age at the time of the abuse is about 9.5 years for both of them. For girls, 94% of alleged perpetrators are male, and for boys, about 88% of the alleged perpetrators are males. So females can do this too. They will present in various ways: the crisis presentations, injuries to the genital area, sexually transmitted diseases, pregnancy, drug overdoses, runaways. Most of the runaways, a lot of the teenagers who are out there now trafficking themselves have been victims of child sexual abuse. The abuse may have been witnessed by somebody that's bringing the child to attention. The perpetrator may have confessed, may have called in an airstrike on him or herself, or the child may have disclosed the abuse to somebody who reports. These kids can also present with insidious behavior problems. They may have regressed and they develop mental milestones in their behavior. They may develop a sleep disorder, school problems or school phobia, depression, acting out in all sorts of ways, and also inappropriate sexual behavior for their age. These are called insidious problems because just like the bellyache, just like abdominal pain, just like vomiting, these things occur anytime a child gets stressed. So the first thing to do is probably not to be jumped to child sexual abuse, but you might want to put it in your differential diagnosis, especially in the face of really inappropriate sexual behavior. Physical findings indicative of sexual abuse, obviously abrasions or bruising to the genitalia, an acute or healed tear in the posterior aspect of the hymen, so below that 3 and 9 o'clock position. A decreased amount of hymenal tissue, again, in that posterior position, below the 3 and 9 o'clock position. Injury to the posterior fourchette or fossa navicularis. So where you see that 6 there, that's kind of that particular area there. Or anal bruising or lacerations. So anal fissures you can get with constipation, you can get them with a lot of things, but anal bruising and lacerations are indicative of physical abuse. Clinically certain sexual abuse. Presence of sperm, obviously semen or acid phosphatase. Pregnancy. The younger the child who is pregnant, the greater the chance you have of having that pregnancy due to some form of sexual abuse. A positive culture for gonorrhea, chlamydia, syphilis, or test of HIV if perinatal transmission has been ruled out is indicative of sexual contact in the prepubertal child is indicative of sexual abuse. Other sexually transmitted diseases that may be due to sexual abuse are genital warts and herpes. But there's a wider differential with those things. And they probably are not going to ask you about that. No, the acid phosphatase comes from semen. Trichomonas is questionable, right? So condyloma and herpes, trichomonas, Gardnerella, all of those things are questionable. Trichomonas is more questionable than say condyloma or herpes. Trichomonas is not as fastidious an organism as some of the others. So there are some other ways that you can become infected. Okay. So let's get. Okay. So then, the question is going to be, do you need to follow this up for potential child sexual abuse? Yes, you do. So you need to talk to the child. You need to probably test for other STDs. So when faced with one STD, you want to test for other STDs. Okay? So that would be how you would proceed with that. In the absence of a history from a child, in the absence of any other STD that is more specific, in the absence of any physical findings concerning for trauma to the genitals, you can't say that the trichomonas was used. But you have to pay attention to it. So sexually transmitted diseases. 5% of sexually abused children will acquire an STD from their victimization. The new AAP guidelines, by the way, for the HPV vaccine indicate that down to the age of 9, children who have been sexually abused should start their HPV series. Because HPV is actually the most common now sexually transmitted disease that we are seeing as the result of sexual abuses showing up later on. And remember, a lot of these kids don't outcry at the time that it happened. The identification of an STD in a child obviously has legal significance as well as implications for treatment, especially if there are other sexual contact of the child or the perpetrator. So, factors to consider when you're testing for STDs are the age, the type of the sexual contact, the time lapse from the last sexual contact, signs or symptoms suggestive of an STD or trauma, the biologic characteristics of the STD. So if you know that a perpetrator has gonorrhea, you're going to be very careful about testing that child for gonorrhea, especially if they've had contact within the last 2 weeks or so of that particular disease. A family member or a sibling with an STD, the likelihood that the abuser has an STD. So the abuser may be a drug user, or the abuser may have been in prison, or something else has gone on, where that abuser may be more likely to be an STD carrier. If the family requests it or is concerned, that's another indication for doing it. And then the general prevalence of STDs in the community. So we do a lot of testing for chlamydia in our right? Because it's just rampant out there, especially in the teenagers. In prepubertal children, unless we are really concerned that there are signs and symptoms of an active STD at that particular moment in time, we do not treat them until we get the test results back. Post-pubertal children, you can go ahead and treat acutely, but the prepubertal ones, unless they've got a discharge or something like that, we're not going to treat until we get the test results back. All right, so the lab and evidence collection, cultures for gonorrhea or a nucleic acid antibody test, again, a chlamydia culture or a nucleic acid antibody test, syphilis, hepatitis panel, HIV at the time of the exam, and 6, 12, and 24 weeks later. These are actually the indications for lab and evidence collection. If you have an acute sexual assault or you have a concern about an STD in a child who's been sexually abused. Cultures of any suspicious lesions, a pregnancy test, a wet mount, and a sexual assault evidence kit when indicated. When is a sexual assault evidence kit indicated? Right. So theoretically, 72 hours. And we know that in children and even in teenagers, we do not get positive results from the sexual assault evidence kit beyond 72 hours. But our friends, the rape victim advocates, have successfully lobbied because some adults will test positive up to 1 week later. So the lawmakers, in their wise judgment, don't realize that children aren't little adults. And so actually the legal rule is up to 1 week. But we know from a medical standpoint it's less than 72 hours. So what do we recommend? If it's within 72 hours, absolutely we do it. If it's beyond 72 hours, it depends upon the nature of the assault. So if you have a child who is alleging penetrating injury to his or her genitalia or rectum, then I would probably go ahead and do it. If they are alleging a fondling injury, I wouldn't do it, but you have to have a discussion with the parents. If the parents want you to do it, you need to do it. So, asking about the alleged sexual abuse. Interview the child and the parents separately. Ask open-ended questions. Use quotes and document what the child said in their own words. Don't put words in their mouth, and pay attention to their affect and any changes in behavior as you're talking to them about what may have happened to them. So, the exam in children is going to be normal 80% of the time. But just like in everything else in this world of medicine, the history is the gold standard for the diagnosis of child sex abuse. So, if you have a normal exam, if they present you with a case of a child with a normal exam, the child is making an outcry, and they ask you if your normal exam refutes their outcry, the answer is no. It does not refute the outcry. All right. Child abuse in the medical setting, or what was formerly known as medical child abuse or Munchausen syndrome by proxy. We don't see it very often here in this hospital. So in that packet for the seniors, I did give you some information on that. I suggest that you read it carefully. But it's a form of child abuse in which the parent fabricates or produces illness in the child. The child is repeatedly brought in for medical care or evaluation. The perpetrator denies knowledge of the cause of the illness, and there's no symptoms when the child is hospitalized or separated from the perpetrator. It carries a very high mortality of about 10% if it's not diagnosed properly, and it also carries a high morbidity. It does not do good things to these children psychologically or developmentally. Children less than the age of 3 years are at greatest risk because they're easier to manipulate. The average time to diagnosis is 15 months. That's a long time in a 3-year-old's life. And it occurs in all different races and cultures and socioeconomic groups. So, it is a form of child abuse that occurs when a child receives unnecessary, harmful, or potentially harmful medical care at the instigation of the caretaker. So the caretaker is coming in, is describing symptoms, or is creating symptoms that makes the doctors jump and do things to the child that if the child doesn't need to have them done. If you stick a needle in a child who doesn't need a blood draw, That's child abuse, right? You're not trying to turn the kid into a voodoo doll. So if the perpetrator is making you do blood tests on a child who doesn't need them, they are making you abuse the child. They're instigating it. So again, the abuse is at the instigation of the caretaker, but performed through nurses and doctors. Perpetrators are oftentimes the mothers, 90% of the time. They may have a medical background. They're often regarded as a model caretaker. They may have a personal history of abuse and neglect themselves. They may suffer from Munchausen syndrome, meaning that they fabricate illness or they exaggerate illness in themselves personally. They may be litigious. They may be looking for money. They like to be the center of attention. They may dislike their kid intensely. They sometimes want to prevent the child's independence. And a lot of them do it for financial, or some of them do it for financial gain or access to charity. So, any symptom or sign, complaint can be a clinical presentation. Children with underlying medical illness can also be abused in the medical setting if the parent is not treating them properly or is, for instance, giving them too much insulin, knowing that they're going to send them into hypoglycemia. Common complaints and presentations involve conditions based upon history alone. So a child who has seizures and mom comes into the ER and says, my child keeps seizing and I've run out of phenobarbital and we just moved here and I need more phenobarbital. That prescription is going to be renewed when in fact the child may or may not have seizures. Common complaints and presentations are apnea, seizures, altered consciousness, vomiting or diarrhea from poisoning, blood in the urine or stool that is not there when mom isn't around, repeated infections from the parent injecting urine or stool into the child or tampering with wounds. And again, some parents also manipulate insulin and glucose. So what are the red flags? A prolonged or recurrent illness with no response to intervention that should clear up the illness, a discrepancy between the history given and the clinical findings, a history of an illness that happens all the time or only at home but never happens in front of a doctor or medical professional. These families will change physicians and hospitals quickly and frequently as people start to catch up to them. The history of a sibling death. This is particularly important when you have a child with a history of seizures or with recurrent apnea. You always need to know about the health and well-beings of other siblings. So the harm to the child is unnecessary medical tests, prescribed medications they don't need and have side effects, and some of them have procedures and unnecessary surgeries. This obviously causes fear, discomfort, and pain to the child. Most parents, and you've all been in the ER when you stick a child one too many times and the mom's like, that's it, you're not sticking my baby anymore. That's a normal reaction. It's a pain in the neck when they do that, but that is a normal protective mother. So you understand now if you have a mom that wants you to do stuff to their kid, that's not normal. So it's really an omission of protective care by the parent. So you need to have a high level of suspicion. You need to know if the history, signs, and symptoms are credible. You need to consider if the child is receiving unnecessary harmful care, and if so, who's instigating it. You do need a multidisciplinary team response, and you need continuous monitoring of the child and the caretaker. Some places do covert video monitoring. There are a number of legal issues with that, so we don't do it here. The outcomes are similar to other forms of abuse. It affects the physical, emotional, social, and educational development of the child. You can have additional emotional consequences for older children who need to become a participant in order to let it carry on. These children can be permanently disfigured or have disabilities from illnesses created or from the medical intervention. And they have lifelong psychiatric and behavioral issues. And it does have, again, I said, a high morbidity of 10%, a mortality of 10% if these children are returned home. The management you can read about by yourself, but basically you are looking towards separation of the child from the parents in order to treat the child properly. Neglect is the most common form of child maltreatment. I started 5 minutes late, so I'm going to finish 5 minutes late. Over 50% of substantiated reports, it is an omission of care by a parent or caregiver that causes harm or risk of significant harm to the child. So it occurs when their basic needs are not adequately met, resulting in actual or potential harm. So basic needs are food, clothing, health care, supervision, protection, education, nurturance, love, and a safe home. So different forms of neglect. There's emotional neglect. Siri doesn't like me. Untreated mental illness. So emotional neglect is actually probably one of the most prevalent forms of neglect that's out there. It is very much underdiagnosed. Supervisory neglect results in injury and ingestions in children. Medical neglect occurs when a child's health care needs are not being adequately met or responded to that result in actual or potential harm to the child. And physical neglect are children who are unkempt, who are not adequately dressed, may also include failure to thrive. Obviously, there's a lot of crossover between these things. Medical neglect may be failure to thrive, may be emotional, may be supervisory, and so on and so forth. So, good question. Theoretically, there should be educational neglect in Illinois is no longer reportable to the Department of Children and Family Service, but certainly it is something that we consider when we are looking at other forms of neglect. Parents are also allowed to homeschool their children. So you roll your eyes. I have special feelings about that too, because it isolates children from their peers and it actually does not allow them to grow up and have the appropriate social interactions that they need. But manifestations of neglect, and dental neglect is one of the most common manifestations of medical neglect that you will see, so you might be presented with some snappers like that. But illness, developmental delay, preventable injury, malnutrition, death are all manifestations of neglect. And again, you have to remember that we as a society are not great about caring for our children. So many of the manifestations of healthcare risks we see with neglect may also occur because children are living in poverty. So the two things, neglect and poverty, as opposed to physical abuse and poverty, go hand in hand. Foster care, and this is the end. So children in foster care are a group with special health care needs. There's a lot of material in your packet on foster care. So compared to children from the same socioeconomic background, children in foster care have higher rates of medical illness. They are more likely to have been drug exposed and to have birth defects and problems related to prematurity. 10% of children in foster care are medically complex. 50% have chronic health care conditions when they enter. So they may have asthma, anemia, lead poisoning, vision or hearing problems. Delayed immunizations are a huge problem. 35% have bad teeth, dental issues, and they're 6 times more likely to have developmental issues than their peers, with 60% of them having a developmental delay at the age of 6. So every state requires a medical examination when children enter foster care. They have to have a screening within 72 hours and a comprehensive screening within 30 days. Thereafter, they need to be seen early and often. It is recommended that as opposed to children not in foster care, that these children are seen monthly from 0 to 6 months of age, and then from 6 to 24 months of age every 3 months, and from 24 months to 21 years every 6 months. So some of you have rotated with us in our clinic. Will see us bringing these kids back pretty frequently. That's what we're doing. So at each visit, the kid is assessed for abuse and neglect, for acute and chronic illnesses, for mental health issues, to see how they're adjusting to their foster care placement, to make sure they have their medical equipment and medications, and to support and educate the parents or whoever may be taking care of them. The health, yeah, correct. Right. So theoretically, so children's brains are plastic. If it's a good, stable foster home, some of those things should correct. Right. The unfortunate part is that most children in foster care for a year or so are moved 3 or 4 times, so they have a lack of stability, and so they are not allowed to catch up developmentally. The initial health screening of a foster child, and this will probably show up on the boards, And HIV, if there are risk assessment positives, hepatitis B, hepatitis C, syphilis tests, hemoglobin, a test for tuberculosis, and a lead level if the child is less than 6 years of age. The comprehensive visit, that thing that needs to happen within 30 days, a complete medical examination, a mental health evaluation, a developmental evaluation for children less than 6, and an educational evaluation for children over 6, and a dental evaluation. So, children in foster care. We're not very good. State does not raise children very well. We do have higher rates of emotional and behavior problems, in part because they are coming damaged into a system that is a very difficult system to maneuver. They're 5 times more likely to have emotional and behavior problems. So 30% of foster care children versus 4% of the general population when they age out of foster care. 16 times more likely to have a psychiatric diagnosis, 8 times more likely to take psychotropic meds. And as adults, obviously, they weigh very heavily on the health system. They use a lot of healthcare services and have higher healthcare costs. They have early pregnancies. You've all seen the young mom who grew up in the foster care system and she's 16 and wants to make the perfect family with 5 children. STDs, drug and alcohol abuse, a lack of education because they've been bumped around from post to point, a higher incidence of arrest and incarceration, unemployment, poverty, and homelessness. So these are all things that we're trying to avoid by giving them early and frequent health care when they first go into the foster care system. All right, done. Who are the seniors that didn't get a packet?